Okay, now we go to the another quantitative platelet disorder. We have here your thrombocytosis. So again, thrombocytosis would be characterized by an increase in your platelet count, and it could be related to either your reactive or autonomous. Reactive is characterized with just a moderate increase in the platelet count, and most likely the patient would have here asymptomatic manifestation. In the case of your autonomous platelet increase thrombocytosis here, that one would have a very high or marked increase in your platelet count, and the patient would have here a thrombotic tendency. Kung sobrang dami ng platelet, hindi din siya maganda, di ba? So that would result here to the clotting process, thrombotic. Pero pag wala kang platelet, the patient would have here a bleeding manifestation. Okay, then this disorder here, increased platelet count related to the following conditions. So primarily, abnormal increase in your platelet count related to your myeloproliferative disorders. We have discussed this already in your HEMA 1. This includes your polycythemia vera, chronic myelogenous leukemia, myelofibrosis with your myeloid metaplasia. Ito yung may natin, diba? Teardrops. And then we have also here your essential thrombocythemia. On the other hand, increased platelet count would also be related to the following disorders like your hemorrhage, splenectomy, iron deficiency anemia, inflammation, and we have also stress, and even your exercise could have here an increase in your platelet count. Okay, now we go to your qualitative disorders. So, qualitative platelet disorder here would have the problem in the platelet function. What you have on this, what you have on this type of disorder here would be, it would have a normal na platelet count. However here, hindi normal ang function ng ating platelets, making this one as your qualitative platelet disorders. Your abnormal platelet disorder here, qualitative, would be related to the problem to the following. Number one, disorder related to your platelet aggregation. These are the functions for platelets, diba? So, platelet abnormality related to your platelet aggregation, platelet adhesion, abnormality related to your platelet secretions, abnormal phospholipid orientation, and we have also here your hyperaggregatable platelets or hyperactive na mga platelets. So we start the discussion with your qualitative platelet defects here with your abnormality in the platelet aggregation. Again, what is needed here for the platelet aggregation would be your glycoprotein 2B3A. Diba? That's the receptor needed for your platelets to undergo here your platelet aggregation. A problem related to that one, okay, results to your Glassman thrombasthenia. This is hereditary disorder, genetic disorder. And Glassman thrombasthenia is inherited here as autosomal recessive na trait. So you could have your homozygous. Pag homozygous, complete absence. Wala ka talagang glycoprotein 2B3A. Pag heterozygous, the patient still have here 50 to 60% na receptor na glycoprotein 2B3A. But still, since reduced siya, I expect also here that the platelets will still have here some abnormality with its aggregation property. Your 2B3A, this is a receptor here for your adhesive proteins like your fibronectin, thrombospondin. Again, it's also the receptor binding site for your ADP. And with your fibrinogen, diba, those are needed for the platelet aggregation. Okay, we have here the significant laboratory test that would diagnose someone to have here your Glanzmann thrombasthenia. So, clot reduction time, so this is a test for your platelet function. So, we will discuss that on the last topic with our prelim. The different tests for the measurement of your platelets. Okay, so the clot reduction time, so ito lang ang abnormal na result na clot reduction time of all your disorders. So, pag may abnormality in the clot reduction time, so that's your Glanzmann thrombasthenia. And another one with the platelet aggregation response. Again, gumagamit tayo ng mga agonist or ligand for you to check here the ability of your platelets to undergo platelet aggregations. So, kung itong ginamit mo na agonist, ristocetin, your Glanzmann thrombasthenia would have a normal result with your ristocetin platelet aggregation test. Kung ginamit mo naman na agonist or ligand for your platelet aggregation test are the following ligand or agonist: epinephrine, ADP, saka collagen. In the case of your platelet, in the case of your Glassman thrombasthenia, this one would have here an abnormal result with the use of those agonists or ligands. Okay, now we go to another disorder, qualitative disorder related to your platelets. So we have here problem related to your platelet adhesion. So we have here to identify the disorder here related to your platelet adhesion. One is your von Willebrand disease. Another one is your Bernard-Soulier. Von Willebrand disease characterized here by the absent or decreased von Willebrand factor. And von Willebrand factor is needed here for your platelet adhesion with your collagen, di ba, para mag-adhere. You need to differentiate between your von Willebrand disease and your Bernard-Soulier because their treatment mechanism here is different from one another. Bernard-Soulier is the defective na GP1B95 complex receptor. Ito naman sa von Willebrand disease, the problem with that is your von Willebrand factor, not your GP1B95 complex. Again, your von Willebrand disease could be treated here by administration of the unit of the blood in the form of your factor 8 von Willebrand factor concentrate. But your Bernard-Soulier could not be corrected by addition of your plasma component na von Willebrand factor 8 concentrate. Kaya nga, kailangan mo munang ma-identify if the patient is really, the addition problem is related ba sa von Willebrand disease ba or with your Bernard-Soulier. Because again, hindi mo pwedeng bigyan ng factor 8 von Willebrand factor concentrate ang patient natin na may Bernard-Soulier because hindi naman yun yung kanyang problem. Again, Bernard-Soulier characterized by either this one is homozygous, characterized by the complete absence of its receptor GP1B95 complex. Pag heterozygous mode of your Bernard-Soulier here, this one would have only still have the 50% of the receptor are still present. But again, it would have a decrease pa din activity in terms of its adhesion property because na-diminish ang kaniyang concentration of its receptor na GP95 complex. Bernard-Soulier, just like your Glassman thrombasthenia, is also inherited here as autosomal recessive. This is characterized here by a giant platelet that would have a diameter of more than 20 micrometer. Diba ang normal micrometer lang natin 2.5 lang, diba? Sa kanya, sobrang laki, more than 20 microliter. Ang kanyang platelet count, mababa, that's less than 40,000 lang. So, anong normal ulit sa platelet count? 150 to 400. So, imagine 40,000 ang mababa. The receptor here for your Bernard-Soulier is made up of the following molecules. GP1B, divided here into your alpha and beta, GP9 and GP5. Entire complex here forms your GP1B 95 complex. So GP1B alpha is 2 molecules, GP1B beta is 2 molecules, GP9 is your 2 molecules, and GP5 would constitute here the 1 molecule of the entire 2:2:2:1 na complex, GP1B alpha beta 95 complex. The production of your GP1B alpha here encoded in chromosome number 17. Your GP1B beta is encoded in chromosome number 22, and GP9 and 5 are all encoded here in chromosome number 3 for their production. Okay, then we have here the laboratory test that would diagnose your Bernard-Soulier. Again, Bernard-Soulier, lahat ng mga qualitative na platelet defects natin, they have a normal na platelet count. Okay, only that, bakit nagkaroon ng problem? Because it's their function, their platelets ang defective, not on the number. Okay, we have here the test that will help you diagnose here someone to have the Bernard-Soulier. So we have the platelet aggregation test where you are observed here for the aggregation property of your platelets. With the use of your aggregating agents or agonists. Vistosetine na result ng ating Bernard-Soulier would have here abnormal na result, whereas epinephrine, ADP, collagen, aggregation test response would have a normal na aggregation response. So you'll notice here na baliktad ang kanilang result ni Glanzmann's thrombocythemia in terms of their platelet aggregation. Ulit sa Glanzmann's thrombocythemia, normal siya dito sa restositine, abnormal siya dito sa AIAC. But in your Bernard-Seul year, normal siya sa AIAC, dito siya abnormal sa restositine platelet aggregation response. Okay, now we have here, I've inserted this topic. So these are the disorders related here to the presence of your giant na platelets. Sobrang laki na platelets. But these are inherited na disorders. The first one, we have your giant platelet with your velocardiofacial syndrome. So disorder here inherited as autosomal recessive. And this one is milder form, the DiGeorge syndrome. And this is heterozygous form of your Bernard-Seul syndrome. The platelet count is only 100 to 200,000. Okay, another disorder related here to your inherited na giant platelets would be your giant platelet with abnormal surface glycoproteins and mitral valve insufficiency. This one is inherited as autosomal recessive with a platelet count of your 50 to 60,000 and is characterized here by the mitral valve or the heart defects. Okay, the next one, we have here your familial macro